speaker, Dr. James Downar. So James is a physician. He's a graduate of McGill Medical School. And as you heard, he's a native Torontonian, but he came to the University of Toronto for his postgraduate training. His base specialty training was in internal medicine, where I certainly met him. But his subsequent career maps out, for me, some of the major shifts in medical education and in practice that have happened over the course of my medical career and that of John David and Dean, who I see is with us. So first, James did a fellowship in palliative care. And palliative care was not really even conceived of as a field when I was in medical school, but it slowly took root probably in the 1970s, and it really was applied to the end-of-life care for patients with really terminal cancer. That's where it started. And a peculiar dichotomy sort of arose in which patients were seen as either receiving active treatment or palliative care, but not both. But James, probably one of the first, also trained in and practices intensive care medicine, probably the most active kind of treatment that you can have. This combination of palliative care and critical care would probably not have been considered compatible by the logic of the 1990s. But as a staff physician at the Toronto General Hospital, James brought palliative care concepts around end-of-life care into the intensive care unit. And he also brought home to me and my colleagues in the lung transplant program how false this dichotomy of active versus palliative could be. He applied the core focus of palliation, that is symptom-directed care, and helped many patients as they awaited transplantation, and really demonstrated to all of us that active care and palliative care can work better as a continuum in cases of life-limiting illness. With his with his interest in decision-making for seriously ill patients and their families, James has been actively engaged in public discussions as well as research and publication in medical assistance in dying. As former member of the Physicians Advisory Committee on Dying with Dignity Canada, he advocated for MAID, and following its acceptance in 2016, he was instrumental in its implementation at the UHN. And this, as we all appreciate, has been one of the greatest shifts in societal thinking and medical practice in our lifetimes. In 2018, as you heard, James took the position as head of the Division of Palliative Care at the University of Ottawa. And as you know from his bio that was circulated, he is pursuing a productive and well-funded research program in end-of-life care and palliative care. And today he will speak to us on early experience with medical assistance in dying in Ontario. So James, why don't you take it away?
Thank you, I will. Thank you very much for that introduction, Dr. Hutcheon. I have to call you Dr. Hutcheon. I can call you Mike. Yeah. But it's really a pleasure again to sort of reconnect with people after some time apart. And I think one of the it is the sort of, it is only in the darkest moments of life that you appreciate the light. When you are drawn away from those close to you and those with whom you've had good and warm friendships over the years, I think it really draws us all and leads us all to really recognize how valuable those are. And sadly, it requires you to have those taken away from you to really appreciate them for their value and the strength that it gives you. So it is lovely to be able to be here with you guys today and talk a little bit about a topic that has affected my life a fair bit and over the past decade, I'll say. I'll sort of share my slides here just to let's see where we are here. Just going to share my slides. And I know that we have a fair bit of time today, so I have some material I'd like to present, but I do want to have the opportunity to have some discussion going, because this is a topic that I think usually elicits a fair amount of discussion and dialogue. Some disclosures: my land acknowledgement that I'm currently giving this presentation from the traditional lands of the Algonquin and Anishinaabe people. I am the former co-chair, as Mike mentioned, of the Physicians Advisory Committee of Dying with Dignity Canada, which was an organization, an advocacy group for legalization of MAID. But now I'm actually employed by a faith-based institution, believe it or not. So go figure. I consider those to be beautifully conflicting conflicts. So I don't really know what that ultimately means for me, but it will color some of the things I will say, I'm sure. I have had speaker fees recently from organizations that have nothing to do with MAID. I've received consulting fees for educational initiatives related to MAID from Jewel Incorporated and CMA, as well as the Ontario College of Family Physicians. And I've been called as an expert witness in the Truchon and Lamb cases as well. So I did have some input into those cases. I want to be super clear, though, that it's not my intention today in any way to try to convince anybody to change their opinion about MAID. I think that, you know, I was, when I testified in court in Truchon, the Attorney General cautioned the court that Dr. Downar was an advocate in this field. I thought that was a very funny thing to say, you know, that I had strong opinions. Like his caution to the court was that I had strong opinions. And I thought to myself, good Lord, is there anybody who does medicine who is not involved who is involved in medicine, particularly for people with chronic illness, advanced illness, that does not have a strong opinion on MAID? I think many of us do. I think that there are some who have shared it, some who have not, but I think we all have a pretty well-formed opinion on MAID. I don't really think that anything I'm going to say here today would change anybody's opinion anyway. I'm going to sort of walk through my own experience and some of the issues that came up. I'm not going to pretend that I'm a neutral person on the subject, but I'm not going to try to be disparaging towards anybody. So feel free to call me on that if I do. It is my interest, though, in really just trying to advance the dialogue a little bit beyond where it's kind of stagnated for some time in Canada. And we've had a lot of discussions. And unfortunately, it has become a topic that has been quite divisive and very unpleasant and acrimonious at times within the medical community. I really hope I don't add to that today. It's not my intention to. So again, learning objectives: to be aware of some of the demographics of people who request and receive MAID, to appreciate the issues that are driving, and more importantly, those that are not driving desire and provision of MAID, and then talk about some of the issues that are currently being discussed as part of MAID legislation in Canada. A quick reminder, and again, it's funny, right? Because I think many of you will have been people who have given many talks over the years. And I always like to joke that I try to be very environmentally conscious. So I drive electric car. My wife drives an electric car, and I try to use at least 95% recycled material in all of my talks. And so in doing so, that enables me to be able to give talks. The problem with MAID is that it changes so quickly that sadly I can't recycle my material. It's really hard to do that. So I have to keep updating slides. And so some of the stuff might be out of date. I do apologize in advance. But as a reminder, for the ancient history, way back to 6 years ago, when the Carter decision was released by the Supreme Court of Canada, ultimately deciding in a unanimous decision to strike down two provisions of the criminal code, aiding and abetting suicide and consenting to have death inflicted for patients who meet certain criteria. And it was done on the basis of Section 7 Charter Challenge. Section 7 refers to life, liberty, and security of the person, which is usually the sort of autonomy provision of the Charter. It decriminalized, as I said, both assisted suicide and voluntary euthanasia. So that being providing somebody with the means to end their own life, and the provision of the life-ending medication by the physician themselves for any competent adult who, number one, clearly consents to the termination of life, has a grievous and irremediable medical condition, including illness, disease, or disability, and who is enduring suffering that is intolerable to them in the circumstances of their condition. So that was the Carter decision itself. And that kind of threw everybody for a bit of a tailspin as people tried to respond to it and come up with legislation that would reflect that decision. They came close with Bill C-14. So in Bill C-14, they defined competent adult as being over the age of 18. Was specified just on the basis of age. They defined a grievous and irremediable medical condition to be a serious and incurable illness, disease, or disability, being in an advanced state of irreversible declining capability and enduring psychological suffering. that cannot be managed under the conditions that they consider acceptable. And then the fourth criterion that crept in that was not part of the original Carter decision, which was that natural death has become reasonably foreseeable. So these were the four criteria that were ultimately passed in Bill C-14. There were committees to study MAID struck as part of this legislation, specified that a committee should be struck to study MAID for mental illness for mature minors and by advance directives. So important point number one, sometimes people talk about these discussions as being evidence of a slippery slope. In fact, these were specified in the law that Parliament was obliged to have committees struck to study this and advise Parliament on whether to change the law. Because at the time of the passage, there's so little published data on MAID for any of these conditions that nobody really felt like you could really base any safeguards or process on any other existing practice, because it simply there wasn't any existing practice for these areas to base them on, as far as they believed. So some of the early concerns for those of us in healthcare and in epidemiology and in policy and in ethics is you want to know a little bit about how the practice is evolving, right? So you want to know who's getting MAID and are the people receiving MAID different than the people who are dying without MAID as part of the regular population? What is their experience? Some of the main concerns that people have flagged over the years, concerns that MAID might actually be driven by a lack of access to palliative care and other things that we consider to be important cornerstones of treatment, and that's a concern. And also a concern that perhaps would maybe preferentially given to those who were socioeconomically vulnerable, where people getting MAID might not want it, or might not have wanted it, but either turned to it out of confusion or out of desperation. And so these are all important questions that we wanted to try to answer as best we can, knowing that it's sometimes hard to convince everybody that you may have answered the question, but here's the attempt that we made. So we actually conducted a fairly large cohort study in Ontario, and we looked at the first 2,200 cases of MAID in Ontario, completed MAID, that is, not requests, and then compared them to a cohort of people in Ontario, all people who died in Ontario. My apologies if this is small. I had to cut and paste out of tables, so I apologize that these are a bit small, but I've highlighted in red the key findings over there on the right that hopefully will be make it easier to take home. So when you compare MAID recipients to everybody who died in Ontario over the same period, the MAID cohort was a little bit younger. The numbers on the right here are not p-values, they're standard mean difference. So again, higher numbers indicate a greater difference. And anything above 0.1 is usually considered significant in terms of statistically in magnitude. So no difference in sex. Interestingly, and not inconsistent with other experiences, those who received MAID were actually wealthier than the average population, and it was not a small difference. There was quite a substantial difference. So, MAID provision. So, although people in the lowest income quintile had a much higher risk of death, and that's something well recognized, people with lower socioeconomic status are at higher risk of chronic illness and death. You can see in the highest income quintile, far lower rate of mortality. And you saw exactly the opposite in the MAID cohort. So much higher incidence of MAID in the richer, wealthier income quintiles, lower incidence of MAID in the lower quintiles, right? So in terms of rural versus urban, I was a bit surprised to see that there was no difference there. What's known as the metropolitan influence zone, so how close you are to the center of an urban area, also didn't seem to be affecting your MAID provision or lack of MAID provision. That was a bit of a surprise to me. Where they died, so where they actually received their MAID, the MAID cohorts were less likely to die in long-term care and more likely in other settings. So these would include hospices. There was no particular difference in where you died, whether it was at home or in a hospital, between the MAID cohort and the overall cohort. In terms of marital status, the people who received MAID were actually more likely to be married and less likely to be widowed. Sometimes a fear is that people will turn to MAID out of loneliness when, for example, their life partner dies and they may be depressed. In fact, it was the opposite, that married people were more likely to receive MAID, or people who received MAID were more likely to be married. I'm sure there's a story there, but we won't go into that. As a married man, I'll be careful. There's in terms of the place of residence before you received MAID or before you died. Very interestingly, that the MAID cohort was substantially less likely to be from an institutional setting, like a long-term care home, long-term care facility, or retirement home, right? So, so you have people. Can you? I apologize. Just one second. I'm getting a bit of an emergency message here, and I'm just going to ask my one of my trainees to quickly see if they can grab it here. Sorry about that. So yeah, again, the fear is that perhaps this would be a way that institutions might sort of, people who are institutionalized or people who are not able to advocate for themselves might be disproportionately affected. In fact, it was the opposite, that people who normally reside in long-term care were extremely unlikely compared to the average population of descendants to be receiving MAID, about 1/5 as likely. So really quite a substantial difference there, that far and away there was a much higher prevalence of people living in private residences or at most assisted living compared to those in institutional settings. And again, consistent with observations from other jurisdictions, people who received MAID were also substantially more likely to be dying of cancer, less likely to be dying of cardiovascular disease, et cetera. And you can see the rest of the numbers splitting out here. Now, this is kind of important to note, right? Because again, one of the fears that people might have, of course, is that MAID is being provided for people that just can't access palliative care. In every part of the world where palliative care is provided, it is preferentially provided to the cancer population. In cancer resources, probably about 2/3 of cancer resources overall in terms of consultations, in terms of home care resources, et cetera, 2/3 or more, 3/4 are provided to people with cancer, even though it's actually less than 1/3 of the population that dies of cancer. To see MAID heavily preponderant in the cancer population and not in the non-cancer population, where palliative care resources and home care resources are less easy to access, is obviously quite an important and notable finding. Certainly, if you're concerned that lack of access to palliative resources is driving this, that would speak very strongly against that fear. Okay, so the 10-day reflection period. So part of the provision of MAID, part of the assessment requires that there's a 10-day reflection period between when you sign your request and when you receive MAID. That could be shortened if the person was felt to be about to lose their capacity or die a natural death. And in fact, about 1/4 of the time, the reflection period was somewhat shortened. Typically, it was for people with very short prognoses, not so much for lack of, at the time of assessment, I should say, not so much for impending loss of capacity. It was more common in patients followed by palliative care and less so in diseases like nerve disorders and respiratory disease, institutionalized populations. This isn't surprising because, again, these are conditions generally that progress maybe a bit more slowly, and so you would not expect necessarily that it would need to be accelerated in those cases. In terms of access, many people were concerned that certainly in the first few years that there were complaints about lack of access. People had difficulty accessing it. Now, you have to take these numbers with a grain of salt because, of course, these were only the completed MAID cases. So there may have been people who requested MAID and never got it for a variety of access-related issues that would not have been captured in this data. But of those who received MAID, about 6% complained, the family, I should say, complained about access issues. And it was more likely in non-cancer, more likely in patients who had at one point been found ineligible prior to being found eligible, and less likely when the assessor or provider was already known to the patient, right? So again, talking about some of the things that seem to be driving this is that people who are less plugged into the system tend to complain more about lack of access than those who are more connected to a system. And again, as we talked about here, MAID recipients were actually very, very likely to come from any group that we normally associate with vulnerability, socioeconomic vulnerability. So people who are younger, people who are less likely to be institutionalized, people with higher income, and more likely to be married. And this again is pretty brilliant, pretty clearly mirroring experience from other jurisdictions that I'll show you. But again, in terms of the degree to which you can assess vulnerability in terms of a demographic profile, this very much speaks against that. And again, also notable was a very high involvement of palliative care. And I'm sorry, I hit some of the slides, but we actually found about 75% of people receiving MAID had been followed by a palliative care team prior to requesting it. And I believe about 80% had a palliative care person involved at some point prior to receiving MAID, right? Now, when you consider that, again, deciding how often palliative care involved is something of a national pastime here in Canada among palliative care providers, that our administrative data studies and our health services researchers can put the number all over the map. But the most broad definition that I've seen wouldn't put the number above 50% of people receiving palliative care prior to death. So to see 80% of people getting palliative care who get MAID, again, very strongly speaks against the idea that it was a lack of access to palliative care that was driving this provision. Now, of course, some people have raised questions. Oh, you didn't assess the quality of palliative care. How good was the palliative care? How long was the palliative care provided prior to death? We'll talk about that in a second. I think that's unlikely to be a factor here, because the simple fact is, I guess if you think about they're saying, well, if the presumption then is that there's this sort of low quality palliative care, and it was in fact the people who are getting not great palliative care who were actually requesting MAID, and the people who are getting better palliative care were not requesting MAID. Okay, that's possible. But then there would be, of course, a third category of people, not people getting good palliative care or low quality palliative care, but people getting no palliative care. And if people getting no palliative care got almost no MAID, it's very hard to argue, like if you're sort of looking over a sort of dose response curve of amount or quality of palliative care, you would expect to have seen the highest incidence of MAID in that group, and you don't. So it really, I don't think that criticism or concern can really be sustained on the basis of this data. In fact, I think it's probably I think it's fairly safe to rule that out on the basis of what you can see here. Now, again, in the US, just quickly looking here, New England Journal, which sadly didn't want to take our data. They guess they'd seen too much of the American data, and so we didn't get into the New England Journal. Poo-poo, they're dead to me now. But in the United States, you see sort of similar things where very small numbers of patients, extremely old, tend to be younger patients, 95+% majority culture, 94% high school graduate. This was done prior to Obamacare. So in fact, seeing only 2% or 3% with no health insurance in a country where something as many as 40% of people might not have insurance really does not speak to a population that has trouble accessing healthcare. Quite the contrary. The other thing is in terms, they actually had information on the end-of-life concerns raised by the patients, and it was not burdens of treatment or burden on family, but almost invariably loss of autonomy and inability to engage in activities. And we'll talk a bit about those and what those mean later. In Switzerland, they did a similar sort of population-based study looking at comparing recipients of MAID to average death sentence, and found, again, the more educated you were, the more likely you were to get MAID, not less likely. That people institutionalized were less likely than people living at home independently to get MAID. And again, similar to our findings, that your socioeconomic position, the higher your income, the more likely you were to get MAID, and not the other way around, right? So again, strongly speaking against sort of these classically disadvantaged populations being disproportionately highly affected. So while people were chewing on our study and talking about why they didn't think we were right, soon after the first annual report on MAID in Canada came out, looking at data from 2019. So our study finished in late 2018. And then data from 2019 was then published. And this was really quite striking. So again, very, very similar data to what we found, except they used entirely different methodologies based on what the assessors were filling out, and found that, again, palliative care services were almost exactly 80%, which is more or less what we found. Of those who did not receive palliative care services, 90% palliative care was available if needed. So again, it was often the case, and we see this where patients just flat out refuse to see palliative care, or they have an issue that's not addressed by palliative care, but it was available. And then in terms of duration of provision, you see on the left that, well over 50% were given palliative care for a month or more prior to receiving MAID, which, the average duration of palliative care provision in Canada is less than a month. So certainly there's no suggestion that these patients are getting MAID later than regular decedents. They seem to be getting it more often and getting it at least as early, if not earlier. Again, the other concern people had raised around disability support services, so many people don't require disability support services, but for those who required them, 90% were receiving them, right? So again, it would be nice if that number were 100%, but about 87, so that's 3.9% of this cohort required and did not receive disability support services. So again, not exactly a number, not exactly a very, very high number. Certainly not sufficient to explain why, not sufficient to explain this as a driving factor in the provision of MAID. So really, on the basis of the data that we have, no good reason to believe that MAID provision is being driven by lack of access to any kind of typical and supported services. Okay, so why are they getting MAID? Again, similar to the US findings, loss of ability to engage in meaningful life activities, loss of ability to perform activities of daily living. This speaks to sort of the purpose of life. And one of the things I learned as I was doing assessments and being involved in early cases of MAID, I am not involved in MAID since moving here to Ottawa, but was involved in a number of cases in Toronto. And it was struck me often in talking to patients that, their description of what suffering was at first challenging for me to fully grasp and understand. But I think I really understand now this level of suffering, and particularly what we call existential suffering, in a way that I don't think I ever understood, even as a palliative care physician, anywhere near as well prior to legalization. That how crippling this existential distress actually is. That as you go through different stages and changes in life, there are many times when people experience existential distress, sort of questioning your purpose or loss of your purpose. That we all have this sort of deeply ingrained self-identity of who we are and what we're here for. And being unable to do that is tremendously distressful to people. And if it's your illness that's robbing you of your ability to do the things that made your life fun and made your life enjoyable, then you're just, it's really quite challenging to understand how you're able to go on like that. I'm going to apologize again. I'm still getting messages here. I'm just going to write a quick message again. Sorry about that. I told locating to forward my calls to somebody, and I'm not sure why they're not doing that. In Oregon, when they looked at this among patients requesting physician-assisted death, and they gave them a long list of things. I mean, many people were concerned that, look, palliative care, we're good at treating pain and physical symptoms. We really don't need MAID if we have good palliative care. But the truth is that when people are requesting this, again, pain is way down the list. So this is a score out of 5. And the highest physical symptom on this list was pain at the time of request, and it ranked 2 out of 5. It was very, very low. It's really about anticipated loss of control and not for physical symptoms. I kind of flagged some of the concerns that get raised around data and research in this area already. People sort of talk about the possibility that an assessor was biased or might not have written down accurately what the patient was actually receiving. But I don't think that really explains the data that we're finding. In most cases, the data being collected is either collected in a blinded manner, Where it was collected in Ontario in our study was actually not collected by us at all, but by a nurse investigator who works for the coroner's office, right? So you've got these well-trained medical professionals whose job it is to look through records and evaluate the care provided. And we were asking them we were going off records that they generated. So they certainly had no skin in this game. They were assigned the task of being an oversight body for MAID in Ontario. And so they did not have really any agenda, and there were many of them. And ultimately these are the assessments that they came up with. So I don't really know how you can do better than that in terms of an unbiased assessment. Also some concerns that it was based on billing data, but it was not based on billing data. The nurse investigators don't even have access to billing data. So it was based on an audit of the actual chart. And for those who have been involved in MAID, you have to send a lot of material to the coroner's office. You're sending, deep, thick wads of paper, uploading them or faxing them. And if they don't think you've sent enough information, they'll call you back and you need to send more. So it is not exactly a cursory review. It's pretty deep. We talked a little bit about the quality of timing and quality and timing of palliative care as well. And again, this idea that there's good palliative care and bad palliative care, and I agree there is good and bad, but that would not explain these observed results, because again, if there was good and there was bad, there should have been none. As well, and it's the none that should have had the highest rate of MAID, and that's not what we found. At the end of the day, also some people kind of flagged this when we talked about the preponderance of the wealthier getting this and not the less wealthy. People flagged and said, well, 15% of the people who got MAID were still in the lowest income quintile, and they said those 15% were probably could have been driven to MAID by desperate circumstances. I can't obviously prove that that's not the case with the data that we have. But I would say that's pretty unlikely. I mean, I don't think that, when you're talking about access to services or the use of a medical service, you don't expect every single person getting MAID to be rich, married, and living at home. There obviously are going to be people across the spectrum who do this. And although, this gives us information about, the socioeconomic drivers and whether any of these factors might have been driving it. I think that, it's fairly clear from this data that, that whatever it is that's driving MAID, socioeconomic deprivation is not, I think, among it. And that's really an important, I think, finding here. I imagine we'll be debating that for some days, though. Okay, so turning back to some of the more recent legal changes. So Bill C-14 and was obviously passed back in 2016. And then in just this past year, or I should say in this past year, Bill C-14, Bill C-7 was passed to sort of enact some changes on the basis of court challenges. So I'm just going to go over what those were. So a quick reminder, Bill C-14 had this extra provision, the natural death has become reasonably foreseeable provision. This was not in the original Carter decision. It was an addition made by Parliament in response to what was sort of multi-advocacy groups banded together and formed and released something called the Vulnerable Persons Standard. And this was meant to try to limit the use of MAID to end of life with the stated aim of not affecting so-called vulnerable people. Now, of course, they couldn't have written anywhere that it was limited to end of life, because that would have been a flagrant contradiction to the Carter decision itself. So this was their attempt to kind of circumvent that. It didn't go well. So it's important when you're drafting laws, and I think I used to sort of criticize laws from other jurisdictions. And now I kind of stopped doing that, because I think no matter where you go in the world, you will find the people who live there will tell you how terrible their law is and how the law is so awful and it really needs to change. And it should be more like your law or this other country's law. And it's a bit like the healthcare system, right? Like everybody complains about it and everybody thinks they should have somebody else's system, which, I think that no matter what you come up with in terms of a law, you're going to expose some flaws in it. But I think you have to start with a vision, right? And understand what is it that you're trying to address and what is it that you are not trying to address. And from that vision and purpose, you then generate eligibility criteria, right? So eligibility criteria for MAID must be clear. They must you must be able to apply them consistently to individuals, and they must be applicable at the bedside. Shouldn't require tremendously complex, convoluted assessments. So, for example, saying a competent adult with intolerable suffering, stable request over time, and a prognosis of less than 6 months, for example, in the U.S. Again, you may or may not agree with less than 6 months, but it is a fairly clear piece of fairly clear criterion that can usually be consistently applied, not always, but usually. So then you have safeguards, and a lot of people really confused and conflated the idea of eligibility criteria and safeguards. So a safeguard is not a criterion. A safeguard is a procedural step that you put in place to ensure that the eligibility criteria are met, right? So, for example, classic safeguard is my child safety gate. So I have 4 kids. I have a 15-year-old, an 11-year-old, a 9-year-old, and a 2-year-old who just turned 3. Now, until very recently, my 2-year-old who just turned 3 was, well, let's face it, he was a pretty dangerous kid at the best of times. And he was particularly dangerous on stairs and around stairs. So I wanted my 3 older children to be able to go up and down the stairs, and of course, me and my wife. But I did not want my 2-year-old to be able to go up and down the stairs. So I installed child gates. Now, I could have just put a giant piece of plywood and nailed like a massive piece of plywood over all my stairways at the top and the bottom. And that way, there is no chance that my little boy could have gotten up or down the stairs and hurt himself. Unfortunately, none of the rest of us could have gotten up and down the stairs either, right? So the purpose of a safeguard, the baby gate, was to have a system in place that would allow the older people to get through, but not the 3-year-old, right? So classic example of a safeguard. The criterion of being old enough to go up and down the stairs, the safeguard is the baby gate. Now, so when you establish things like witnesses are not an eligibility criterion. They're a safeguard to ensure that the person is competent in asking for something. Duplicate assessments also to assess competency and to ensure that they are intolerably suffering, et cetera, and to make sure that all the other criteria are met. The reflection period is a safeguard to ensure that the request is stable. So these are not eligibility criterion. These are not criteria, these are safeguards. So understanding, of course, that there's the difference between a criterion and a safeguard, and now understanding the difference between a safeguard and an obstacle, right? So an obstacle would be like nailing a piece of plywood over all of my stairs. It is something that just generally makes something hard to access, rather than discriminating between those who are eligible and those who are not eligible, right? So some people put things like, you must have 3, 4, or 5 witnesses, right? Not clear what 3 witnesses or 2 witnesses does that 1 witness doesn't do, right? So, but the more witnesses you require, the harder it is to get those witnesses, and thus the more generally difficult it is to access the service. Longer reflection periods, for example, are they necessary? So that's why it's really important to critically analyze a safeguard to make sure that it actually is tied to an eligibility criterion or more than one eligibility criteria, rather than is just something that's hard to get, because that's not a safeguard, that's just an obstacle. So when it comes to natural death being reasonably foreseeable, the government understood that people might have questions as to what that means. So in the Bill C-14 glossary, they helpfully provided the following 3 explanations. Natural death reasonably foreseeable is an irreversible decline towards death, even if that death is not anticipated in the short term. Okay. Natural death has become reasonably foreseeable means that there is a real possibility of the patient's death within a period of time that is not too remote. And then finally, taking into account all of the patient's medical circumstances, they were on an irreversible trajectory towards death. Yeah, so if you're like me, you probably scratch your chin reading this. And maybe I'm just a glasses half empty kind of guy, but I sometimes ask people, like, if you don't foresee your own death, tell me what you do foresee. Like, I think all of us are obviously on an irreversible trajectory towards death, and deciding when that starts and when it hasn't yet started is more than a bit subjective, I would say, for most people. My challenge around this provision, of course, was related to, well, I'll get to that in a second, because others made attempts to clarify reasonably foreseeable death. So the Canadian Association of MAID Assessors and Providers came up with clinical guidelines, and they very helpfully said that you should call reasonably foreseeable death should be interpreted to mean reasonably predictable. with no specific time frame. And God bless them, they're my friends. I love these people. I did not find that very helpful. And in fact, when I was at the Hutcheon trial trying to explain to a Francophone court what the difference was between reasonably predictable and reasonably foreseeable, if you actually enter predictable and foreseeable into a French translation like Google, you actually get the same word in French. So it was not helpful. There was a court case in Ontario where somebody was applying in advance, essentially have a court clarify whether this patient had a reasonably foreseeable death, because one assessor had said they didn't think that she did, but then the third assessor was willing to do it, but didn't want to get in legal trouble because of what the second assessor had said. And the Justice Perel in that case said all physicians are equally capable of determining whether the criteria factors are or are not satisfied, but unfortunately didn't actually give us any instruction for how to interpret it. They just said it's something that every doctor can do, and you shouldn't have called us. Nova Scotia College of Physicians and Surgeons came up with something that I thought was a little bit more helpful, where it was kind of a bit of a Schrodinger's cat or a Heisenberg uncertainty principle approach to this, where you have a sort of provider must be able to predict when the patient will die or how the patient will die, but not necessarily both. So you need to know when they'll die or how they'll die, but not both. So again, for fans of Schrodinger or Heisenberg, I think you're, well, maybe not Schrodinger, we'll go with Heisenberg. So when we look at predicting death, a lot of us talk about describing mortality rates within a population, a defined cohort or population. And everyone's favorite Kaplan-Meier curve, which essentially is a way of trying to describe or express what, the rate at which people will die in that population over time. So you have on the x-axis, you have time in years, on the y-axis, the percent who are still alive. And over time, certain amounts die. So whenever you're trying to make a prediction about how long somebody has to live, you can look at their sort of peers or people similar to them and describe that cohort, and then look at how that population would do. Now, the challenge is, of course, how to interpret this. Like, at what slope or what kind of curve would tell you that somebody has a reasonably foreseeable death, and what kind of curve tells you that they don't, right? So obviously this, here where very few people are alive after 5 or 6 years, probably fair to say that this is the population of people that do have a reasonably foreseeable death, if you had somebody who fit into this group. But if I raise this, if I lowered the slope of this, right? So fewer people die, fewer people die, fewer people die. I mean, we would keep going, and eventually some people will say, well, now it's no longer reasonably foreseeable. And I'm pretty sure that all of us on this call right now would not agree where that cut point is. So at what mortality rate over time does one have or not have a reasonably foreseeable death? So it wasn't just, to my mind, that I just didn't really know what it meant, but it was also that it was grossly inconsistent among people, that you just wouldn't get the same answer. So again, when this went to trial at Hutcheon in Quebec, the Attorney General and their experts sort of argued that it was very important for preventing patients with a primary mental illness from receiving MAID, and it was a safeguard for those who are disabled but otherwise expected to have a normal life expectancy. So again, these were the arguments they made. And again, I think it highlights some big problems with how this was viewed. Ultimately, it was not viewed as a criterion. It was viewed as a safeguard, and it wasn't a safeguard. It was a criterion. So it was never meant to prevent people from accessing MAID, simply because they were disabled. It was never meant to prevent people from accessing MAID for anything except primary mental illness, but even then it was not put in for that purpose. It was really meant to describe somebody who was, on a trajectory towards death, and that was not part of the Carter decision. So it wasn't actually within the scope of Parliament to make that judgment call. So the arguments made against it at the trial, and I made many of these arguments, that I didn't think it really added anything to the other criteria. So I would often say, if you have a serious and incurable illness, you're in an advanced state of irreversible decline in capability, and you have intolerable suffering, I'm not aware of any condition that would meet those three criteria, but would not have a reasonably foreseeable death. I just can't imagine a condition where that would be true. So I really didn't think it helped in any way to define the population. also in terms of protecting the vulnerable, because our classic impression of who is actually vulnerable, right? So people who are vulnerable are typically people with more advanced illness because they may be experiencing cognitive decline. They may be less able to advocate for themselves, for example. They may suffer from delirium or other cognitive impairments related to their illness. And basically all of those become more common the closer you are to death. The further you are from death, you are far less likely to have any of those things. So it was really hard for me to understand why this criterion actually did anything. It would almost exclusively include the vulnerable and not and exclude the non-vulnerable. So I think that was not a very strong argument. And I think it really did add a lot of confusion that it was being interpreted inconsistently across the country, and that ultimately, if you really wanted to protect the vulnerable, focus on individual assessments of vulnerability and capacity, and that was the way to do that, rather than trying to sort of come up with demographic approaches or broad criteria that you think might capture slightly more vulnerable people than non-vulnerable, because that was going to backfire. And ultimately that argument did hold the day, and that the Hutcheon court decision in Quebec did strike down or did find that provision of Bill C-14 was incompatible with Carter. There were other issues that were raised subsequently on hearings from the government, that there were a lot of issues getting two witnesses, that actually finding two witnesses who were not that met the criteria for who could be a witness was actually not as easily said as done as said, I should say, for many people who had advanced illness and maybe didn't have large families or didn't have a lot of what we call social capital to mobilize. There's a volunteer service for Dying with Dignity Canada that was used heavily in many parts of the country to simply witness requests, because it was so hard for many people to find witnesses. The 10-day reflection period also was challenging because so many people lost capacity on the way while waiting for that to go through, and that led to frustration for both patient and family member alike. And that ultimately people were concerned that they were moving up their dates for fear of losing capacity, or worse still, we would see cases of people who would sort of withhold their own pain medication and other comfort medication because they were worried that if they took too much of the medication, they would actually get side effects and essentially become delirious and not be able to be competent to request it at the end. So they would essentially deliberately allow themselves to suffer just to maintain capacity. And of course, there were ongoing questions about mental illness advanced directives in mature minors, because although the government did convene the Canadian Council of Academics to write reports on this, when the reports were produced, the government said that made it very clear that these were non-binding reports and that they were not obligated in any way to act on them. And they kind of disappeared, and there was no further action taken at that point. So that was a bit, I think, disappointing for many people, because it was, regardless of what you felt about Bill C-14 and the provisions here, you can understand that when people see that kind of response, they get upset, right? They feel like they were sort of placated with these provisions in the original bill, and then as soon as the reports were done, they were just ignored. So the legislative changes that came about in Bill C-7 were sort of as follows: that you had two assessment pathways, one for where death was, again, they got rid of the reasonably foreseeable death as an eligibility criterion, but they created two separate pathways based on whether the death was reasonably foreseeable. So I'm still a bit confused, because I don't really know who would meet the other three criteria but does not have a reasonably foreseeable death. But assuming that others can, in the reasonably foreseeable death pathway, there was no longer a requirement for any reflection period, because by the time people actually got to the point of being able to get assessed and request it, that people felt that really everybody had been reflecting on this for a very long time, that these were pretty stable requests. There was also Audrey's amendment, which was the fact that if a patient had requested, being found eligible, and picked a date to go ahead, they could actually sign a piece of paper at that time to say that they would waive the need for final consent. So if they lost capacity prior to the date where they had scheduled to have their maid, that the maid could go ahead and be provided on that day, even if they lost capacity. So they would not feel the need to move up their date for maid, so that they wouldn't lose maid as an option for themselves. And in the death is not reasonably foreseeable category, they actually established a much longer reflection period of 90 days. And there were many of us who argued for that, saying, look, if you don't have a pressure of time, it would not be a bad idea to extend the reflection period to make sure that it is really a durable request, and it does give people an opportunity to ask and seek out other opinions. And speaking of other opinions, there's a provision that the second assessor should have expertise in the condition causing the suffering. So some people ask that, some people suggest that when you legalize MAID, you should make one of the assessors be a psychiatrist or a palliative care doctor or whatever. Practically speaking, that's very challenging to do, trying to make sure that those individuals are available in a very timely manner, especially given the time frame for a lot of these requests is quite short, and these patients can suffer while waiting for those assessments. But in this case, where time is less of a pressure, when you're trying to actually make sure that this person understands their options vis-a-vis the underlying condition that they have, I think not unreasonable to ask that one of the assessors be somebody with expertise in that condition, who can really make sure that they do understand those things. Again, got rid of 2 witnesses and just had the one. And then there was interestingly, the Senate introduced a couple of provisions that ultimately one got rejected and one got accepted. This sort of a provision where they said mental illness could not be used as the primary indication for MAID, but that expired. That's going to expire in 2 years. So essentially, it sets the clock ticking, where the government will not be able to just strike a committee to study it, but then decide to ignore it when they feel like it. They actually, this sort of puts them up against a deadline where they have to be prepared to actually pass a law to make it clear how mental illness would be, in what situations somebody with mental illness would be eligible to request and receive MAID. And that's really was the purpose of this sunset clause there, was to not allow the government to just simply prevaricate and duck the question as they did on the first go around. Sort of moving towards the latter part of the talk here, I think that there obviously were a number of concerns raised about MAID in the course of discussions around C14 and C7. And again, I've talked a little bit about some of these already, but I'm going to talk about my own perspectives on some of these issues, not in the sort of sense of saying MAID is good. I'm not trying to argue that MAID is good, and I don't think that MAID is something we should be striving to pursue as individuals or as a society. It's really just about choice and allowing people to make those decisions for themselves. But at the same time, understanding that as much as we can, we want to put choice around people, that not just MAID, you want to have other options. The concerns that sometimes get raised, and I struggle sometimes with following the debate in other jurisdictions, because it's like people kind of recycle the same arguments from the 90s and early 2000s, as if there hasn't been any data released. And we actually have a lot of data around the practice of MAID now from many jurisdictions that tell us a lot about MAID and why it's used. And why people are asking for it, and what scenarios it gets used, and what seems to be the effect overall on services and other aspects of the healthcare system. I think it's important to know these, because I think we need to move the dialogue forward a little bit. There actually is concrete action we should probably be taking, and there's a lot of learning to be had here. But a lot of the older fears and concerns that people raised have proven not to pan out. And I think it's important to know that, because there's other stuff we need to focus on rather than sort of recycling these old discussions. So one concern that people talked about is this practice of involuntary and non-voluntary ending of life. Does the creation of a more permissive regime actually lead to people simply just flaunting the rules and ending people's lives without going through any of the processes, and just deciding that we're going to just end people's lives without asking them? Does it lead to erosion of palliative care services and a decrease in palliative care services? Is MAID driven by issues that palliative care can actually address? Is it driven by a lack of access to opioids? Is it driven by isolation or lack of access to social supports? Does it have a disproportionate effect on the vulnerable? I've addressed some of these already. I'll try to address the rest of them now. So opioid availability. I've put 2 maps of the world here for us to look at. And I don't think you need to look at them too closely to recognize a few simple patterns. So on the left, you have the opioid consumption map. So this is how much opioid per capita is consumed in that country. The countries with the highest consumption of opioids worldwide are in blue, dark blue. On the right, you have the countries where voluntary assisted death or MAID is legal. So the green and dark blues are the countries where it's legal. If you look at the map on the left and you look at the map on the right, you will see that they are almost perfectly mapped over each other, right? So the countries that have the highest opioid consumption are the countries that have legalized MAID. The countries that legalize MAID have the highest opioid consumption. Again, this is not an RCT. You cannot randomize one country to get lots of opioids and another to not get opioids. But when you look at a map that maps out this well, it's very hard to argue that societies and individuals and others in general are seeking this out and legalizing this on the basis of lack of access to opioids. It doesn't seem to be the case. In terms of non-voluntary ending of life, this has been shown in the Remelin Commission, and there's a group in the Netherlands that actually studies this through these anonymous death certificate surveys that have been going on for years, and in fact, even more than a decade before MAID was legalized in the Netherlands. Doctors could fill out the type, indicate the type of care they provided at the end of life to people that they were in charge of. And this practice of what they call life-terminating acts without explicit request or lawyer was actually almost 1% of all deaths prior to 2001. And in 2001, voluntary assisted death or voluntary euthanasia was legalized at that point. And you'll see that Lauer went down, not up. So again, creating a regime whereby people are actually able to do this legally doesn't seem to lead to more of provisions illegally. In fact, it leads to fewer. People can have much more explicit and open conversations and be more clear. In every country in the world that has ever been able to study this in any way, there is a fairly substantial proportion of people who provide non-voluntary euthanasia, even countries where euthanasia is completely illegal. And it is no higher in those countries where MAID is legal. In fact, it seems to be lower when you look over time. When you look at MAID and whether it replaces palliative care, again, I'm a palliative care physician. This is something of great interest to me. And there's been a lot of talk about how rates of MAID have gone up in countries where it was legal. And the answer to that is kinda, but so if you look in the Netherlands here, the group of on the top, so this is looking at end of life practices over time, 2001 through 2010. You'll see that MAID initially went down, but came back up, and it was more common in 2010 than 2001. But if you look at what practices that would be considered palliative care, so intensified alleviation of symptoms, that's jumped 16% over the same time period. So although MAID is going up, palliative care is going up dramatically more, which speaks to a really important trend that you see in the literature, where actually palliative care services and palliative care practices seem to be getting more common over time. So be very careful to put any increases in the practice of MAID in the context of improvements in provision of palliative care. And here's a study from Belgium that essentially shows the same thing, that over the sort of first 12 years, where sort of first, well, in this case, 15 years, legalization of MAID in Belgium, you're seeing about a 2% overall increase in the use of physician-assisted death and a 20% increase in the use of practices that we would consider palliative care. Again, you may not agree, or you may disagree with the practice of MAID and find it something morally that you don't like. But when you look at numbers like this and see the growth of palliative care, it's hard to argue that this is happening at the expense of palliative care. In terms of funding and service support, multi-country comparison. Now, again, it's tough to do this type of study because it's observational, right? We're not randomizing countries to legalizing MAID and some to not legalizing MAID. You're just looking at countries that legalized MAID and those that didn't, and comparing growths in funding, and you have to benchmark it to something. So using the United Kingdom as the funding benchmark, which is a pretty standard practice, Belgium had a similar growth in the provision of palliative care and palliative care funding to the UK over that same time period. Netherlands and Luxembourg were actually not high performers in palliative care prior to legalization of MAID. And their funding for palliative care grew so dramatically in that time, they actually went up to join the UK and Belgium in the top group. So again, speaking to the fact that, it's certainly not the finding of other jurisdictions that palliative care services suffer or get less funding as a result of legalization of MAID. Again, that's not a guarantee, of course. countries can choose to cut funding and services can be cut anytime. It just doesn't happen to have been the case anywhere that's been studied. I kind of talked a bit about existential distress before, and I'm going to come back to it now because I think it is super important, right? That it is something that's a bit hard to study because we don't really have a standard universal definition. I use the term sort of loss of purpose because people experience this at many points in their life where you sort of go through, a divorce or lose a job or a midlife crisis. And then, of course, many sort of angsty teenagers, early 20s years of college students just not really sure what to do with themselves and get really feel anxious and distressed about it. And then, of course, when you get a terminal diagnosis and you start to lose the ability to do things, you lose, to some degree, you're losing your identity, right? So you develop this identity over years, and humans are very relational beings. Very much, we define ourselves often less in terms of who we are to ourselves as who we are to others. And we're part of an important network, and others play roles in our lives and we play roles in theirs. And then when you can't play those roles anymore, like you can't drive your kids or your grandkids to hockey, you can't do the gardening, you can't, you can't go to do your social activities like you used to. Avid readers who can't read anymore because their vision is gone. People who are fans of music and can't hear the music because they get this horrible rushing sound or tinnitus in their ears as a result of their illness. These are things that are not sort of trivial inconveniences for some people. For some people, these are fundamental assaults on identity. And the enforced change of relationships, and in many cases, is really hard. So somebody who's been a giver all their life and a sort of self-made person, somebody who, and I think of the people that I was involved in with MAID, the number of sort of doctors, lawyers, venture capitalists, just people who are all about the sort of, self-made person. And they like things done their way. And they like to get up and at the end of the day, whatever got done because they did it. And their effort was, if there was ever a difficulty that needed to be overcome, it was going to be pure gumption that was going to get them there. They were going to muscle their way through it because that's how they got through life. And here's something they couldn't muscle through. And that was a really difficult thing for them to be the strong person who felt like they did things for everybody, the provider, suddenly becoming bound and needing somebody else to change their diaper or help them get to the commode chair. Unable to go outside, unable to pick up their grandkids, unable to go to the park, unable to read their books or go to listen to their music. These are not minor trivial inconveniences. And it is true to say that, yes, we can provide you with services that will help you get to the toilet. But it's not that they don't have those services and they have those supports. It's that they need them. The assault on their dignity is that they need them, not that they don't have them. And that's the thing that I've sort of come to understand, I think, a lot better with time, is being involved with these people. Also that, the idea of audiobooks and stuff like that can certainly work for some people, but for many, it's not the same. They can't, they are not able to enjoy the experience and the things that they enjoy doing the same way. And it's really important to understand that, right? Because we actually don't have a lot to offer people with existential distress. There is no actual standard, there's no accepted or effective therapy for this, from the literature. And I think that this, to me, has been a huge area for me to open my eyes to study, that I want to really look at existential distress and help. Now, it's interesting because in Canada now we're up at about 2% or a little bit more of all deaths are MAID deaths, but existential distress in the dying might be as common as 20 to 30%. And severe existential distress is rated by people as being the worst experience, far worse than pain or shortness of breath or any physical symptom. It's really a horrendous experience for them. And I think our efforts to address existential distress are probably the best way if people feel strongly against MAID, that they are disagreeing with the practice of MAID, understanding that it's not going to be made illegal again in this country. If you want to drive down the provision of MAID, it would be really good to understand this existential distress and really work hard to develop new treatments for it, because that's the way forward. And that would be completely uncontroversial to everyone. Everybody wants that. And 9 out of 10 of the people who have existential distress are not asking for MAID. So you're going to help people far beyond the practice of MAID. The mental illness issue is going to come up now over the next 2 years. And again, it's a bit of a difficult case, because trying to apply the sort of paradigm of Carter and C14 to this, it's not immediately obvious how you do that, right? So, what is the cause of distress and can it be relieved? So not only can mental illness cause distress, but it can also raise questions about the capacity of the person. So you need to have a way of ensuring that this person is making a capable request if they can. And you also have to determine whether somebody actually has distress that cannot be relieved, essentially an incurable illness. And the Canadian Psychiatric Association was very clear to point out that rarely, if ever, should mental illness be considered irremediable. And I think that that's not an unfair comment, right? Like, I think it's hard to determine that mental illness is truly incurable. There is a condition known as, well, we'll get to that in a second. There's a condition known as treatment refractory depression. And if you have treatment refractory depression, you could be forgiven for believing that your depression is refractory to treatment. But unfortunately, that's not what that means. What it means is that you will have, there's a standardized definition of it, and it defines this sort of hard to treat group. But there is actually even an appreciable spontaneous remission rate in this population. So understanding how you go from treatment refractory depression to truly incurable mental illness is going to be hard for a lot of us, I think, to wrap our heads around. It's a relief to know that there actually is a committee that's been struck by the federal government that includes a lot of really smart brains, including Order of Canada Professor Emeritus, or I think she's University Professor now, Donna Stewart, who many of you may know from Hutcheon, who has been quite involved in this field. And again, there are others, Justine Dembo, who's sort of much more junior, but obviously off to a bright career. And people who I think can maybe try to look at some of the literature that's out there and start to come up with usable frameworks for applying this, right? Because again, mental illness is really common, and trying to determine when it is incurable is not going to be easy for a lot of us. I think, unfortunately, there's also been a bit more sort of rhetoric around the idea that, no, we can't do this until we've done a large prospective study to determine when something statistically is incurable. And they talk about the need for science and the need for science, but unfortunately, what they really should be doing is calling an epidemiologist to explain to them how hard it is to statistically prove that something is impossible based on prior events. That is actually a really challenging thing to do statistically. So the number of patients and patient years that you would need to enroll in order to establish that the point estimate of recovery is 0, and that the 95, 99, 99.9% confidence intervals are tight around 0. That's a lot of patients. And now you're going to take these people with refractory depression and follow them for how many years and hope that none of them commit suicide, in which case they're a loss, and you won't know. It's a really big challenge. So I don't know that this is necessarily a question we can expect an epidemiologic answer to. I think we have to come up with something that's workable. This has been done in other countries, of course, Belgium and the Netherlands, where this is legal. And I think we can borrow from their experience a little bit, although we may want to change it a little bit. I think we've got some good, smart people working on it, and I look forward to seeing what they come up with. But again, ideas of what you standardize in terms of treatment. A lot of these individuals have not only complex illness, it's not just mental illness, they'll have complex chronic illnesses and multimorbidity. And then of course, a lot of these people have social deprivation. So they're socially isolated. They may have low socioeconomic status, marginal housing, and other things. To decide to what degree social deprivation may be driving the request is not exactly straightforward. And are we in a position to even address that? So we sort of say, well, you can't have MAID because you're marginally housed, but I can't give you a better house, or I can't change the fact that you don't feel safe in your social housing. It's hard to know what to do with that information. So I think we need to be very practical and pragmatic about our approach here. Moving on and nearing the end here. So made by advanced directives. I'm very torn on this issue personally, and I'll be open and say that I'm not, people often ask me how I feel about it. And I have to say, I'm just not sure whether I think we should or should not do this. And I mean, if you try to pin me on an answer, I'll give you one, but I'd prefer not to. My struggle with MAID by advanced directives is this. The decision-making paradigm for MAID that I think I've been involved in for up until now is that the value of someone's remaining life, right? And the potential for enjoying something in the future is part of what they're considering. And then the severity of the suffering and putting those two against each other, right? So again, is chance of recovery, the chance of enjoyment in your future set against how bad your suffering is and how bad it's likely to get from here on. And that's really what you're sort of weighing in the balance when you're trying to make these decisions about whether to go forward with MAID or not for yourself. The problem is that we're not always very good at imagining quality of life in a future state, right? So it's one thing if somebody is currently experiencing the suffering and can make those assessments contemporaneously about themselves. It's another thing to try to imagine in a hypothetical future state, how would I feel about the value of my remaining life and potential for enjoyment versus the severity of my suffering in that state? Because we don't really know how we're going to feel. We don't know how bad the suffering will be. Classic examples, the amputation studies, looking at people who imagine what their quality of life would be like with an amputation, and they think it'll be terrible, and then they get the amputation, and it's not so bad. In fact, it's no different than before the amputation for most people. So again, very important to recognize that limitation. The other thing is that we're not always very good at writing care instructions that can be followed. And I say this as an ICU physician. I cannot honestly remember the last time I read an advanced directive that was useful. They're always hopelessly vague or hopelessly specific. So they either don't tell you really what to do, or they apply to a situation that you're simply not in. The scenarios may look clear on paper, but in real life, so if I can't recognize my family, okay. If I have dementia, I can't recognize my family, I would want MAID. All right, well, what if you see your son and you confused him with your other son? Right? What if you saw, one relative and you recognized them, but thought they were a different relative? Does that mean that you didn't recognize them as family? That's more challenging, right? If I can't feed myself, well, anybody who's cared for and been involved in the care of somebody with dementia knows that some days they can feed themselves and some days they can't feed themselves, and they can feed themselves some things and they can't feed themselves other things. And so how do you know? These may seem like hard and clear lines, but it's actually not always that obvious when you've crossed them. If I need diapers, well, people can need diapers when they have a UTI, but then they don't have a UTI and then they don't need diapers, right? When you cross that line is not always straightforward. And so I think there's a lot of fuzziness to me in the idea that you would do MAID by advanced directives. Now, that said, we make all kinds of care decisions on the basis of instructions left in this manner, right? So I routinely am involved in withholding or withdrawing life-sustaining measures, not only based on what the person might have said, instructions or vague statements that the person might have made, but I'm relying on the next of kin to tell me what they said, which is sort of like also introducing another degree of uncertainty around that. So I don't think I think if you're going to apply a double standard, i.e. you're going to allow life and death decisions about life-sustaining measures through advanced directives, but then you're going to say that you're not going to do that for MAID, you need to justify that, I think. And can you justify having a double standard for MAID compared to other life and death decisions? Some would say yes, and some would say no. And I think whatever decision we come up with, we have to be able to defend. I mean, at the end of the day, I also don't really understand how you could possibly come up with safeguards for this, right? Like, how would I know if somebody comes to me that really is the scenario that the person was thinking about when they wrote this document? Obviously, the document would only be brought to my attention by a loved one, would be most commonly brought to my attention by a loved one. And we know that if someone's going to die, your loved ones are the ones with the most conflict of interest, both in terms financially, they have the most to gain financially. There was a history of physical, emotional, sexual abuse. It is very likely a family member that would have been involved in that. So I don't have a way of ruling that out. So it's really quite a challenge, to make a system that you can rely on, around MAID by advanced directives. So again, I'm not saying, your challenge ultimately is that you can try to sort of do big tent or small tent approach, and understanding that if you do a small tent approach, if you do a big tent approach, and make it more open to people getting it, then some people obviously are going to get in that maybe shouldn't have or wouldn't have wanted it, and they're going to receive MAID because they left poor instructions or there were other factors. Or you can make a small tent, and then it's very less likely for people to be able to access MAID who you didn't think should have been able to access MAID. But then there are a lot of people, of course, left to suffer and left out in the rain. And that's how you find the balance between that is ultimately, I think, not a medical or an ethical question. I think it's a question for society to decide what is our risk tolerance as a society on this question, and how important is this to us? Again, I think we'll all have our own answer to that. And of course, the people who feel most strongly about this are actually our elderly, who really feel like it's important that they should have access to this. I'm routinely struck by how strongly our senior community feels on this issue whenever I talk to them, far more strongly than I do. So just wrapping up here in terms of the talk here, bottom line, the things I was trying to present today is that really ultimately, I don't believe that MAID is driven, I think the data supports this, that MAID is driven by availability or the quality of palliative care or the availability of quality of home supports. I don't believe it's being driven by socioeconomic deprivation or isolation or even access to opioids. I think that's been fairly clear in the data. I think MAID may be driven by this existential distress, which seems a pretty strong signal, and certainly by illness type. For some reason, people with cancer and ALS far and away are asking for this, like, huge proportion of people dying of cancer and ALS are asking for MAID, and 30 times more frequently than people dying of other conditions like heart disease. I'd like to know why that is, because I don't think it's entirely clear to me why so many people in those disease groups request it, whereas so few people in others do. It's not a small signal. It's a very strong signal. I think the lessons for Canada so far, right, is that ultimately legalizing MAID and supporting palliative care are not mutually exclusive options. And unfortunately, in my community, things can get pretty acrimonious around the discussions of MAID, that people really feel like MAID is something that must be kept away from palliative care, must be kept out of hospices, that this is dangerous. The data don't support that. And in fact, my own experience with this has been pretty clear, that the distress felt by members of the public is exclusively when they find themselves in a palliative care unit and suddenly discover that unit does not allow MAID. They get upset and they push back and they get very angry. I've had far more people refuse to go to a palliative care unit because they don't provide MAID. I have yet to meet anybody who proposed, who, when considering whether or not to go to a palliative care unit, has told me that they would only go to a unit where MAID is not provided. For example, I think we as a community really need to kind of move beyond this a little bit and be a bit more MAID neutral when it comes to these issues, because the population feels very strongly about it. And the sort of steadfast approaches against MAID, I mean, maybe they may be deeply felt and honestly felt by those of us who just feel morally like this is the wrong thing to do. Please understand that 9 out of 10 Canadians feel the opposite, and that if we're in the business of trying to support patients and giving them their choices and their options, we're gonna have trouble balancing those two things if we're trying to exclude MAID. Improving end-of-life resources obviously is a great idea, and I think we should be doing it. Improving social supports, et cetera, social housing, all these things are great ideas. But that's not going to affect provision of MAID, because that's not what's driving provision of MAID. That's a common misconception. I think we need to just move on from this. I think the big area of effort should be an expansion into existential distress, understanding better the causes, and most importantly, the treatments. And I've got a few research programs looking at different options now that I'm very excited about, and hoping to be able to share some data soon that might hold some promise here. Fundamentally, though, as we rewrite laws and as other jurisdictions, I mean, it seems almost every month brings a new jurisdiction that legalizes MAID. Be very careful what you put in your laws. So in Canada, we have a long history of people trying to essentially put obstacles into laws. And this happened with our abortion law that led to the Morgentaler case. We're going to get punished for it, right? So in the case of abortion, adding these sort of ethics communities that had to approve every case, and some hospitals were putting like the town bishop on the ethics committee, or have an ethics committee that only convened every 6 months, and you had to get the abortion before whatever, 12 weeks. This is a very cynical approach to trying to solve a complex social problem. And the courts will punish you for this, right? They'll take it away. And then we'll be left with nothing, or left scrambling to replace the law in a short time period, leading to yet another cycle of this very emotional debate. I think that what we really need to do is just sit down, maybe maturely as a society, and just try to decide what actually could work. Make reasonable procedural steps and safeguards, not obstacles, and approach things in a constructive rather than a cynical manner, which I think is a vital lesson for the future. We've just been burned by this so many times, and I just hope we learn from it eventually. Ultimately, you have to recognize that almost every jurisdiction on this list is going to legalize MAID soon. I really can't, it's hard for me to keep an up-to-date map of all the jurisdictions that are legalizing it. We're more than 10 jurisdictions in the US. In the next decade, I think you're going to see another 10 to 15 jurisdictions in the US legalize. Every region of Australia will legalize it. New Zealand has. I was deeply shocked to see Spain, Portugal, and Italy, and Austria have now all legalized either through statute or through court decision in Austria, constitutional court in Italy, but through act of parliament in both Portugal and Spain, right? So Catholic countries that have legalized this. I don't see how this doesn't become legal across Scandinavia, France, and of course the UK in the next 5 to 10 years. Again, I'm hoping that I hope that this will not turn into yet another opportunity to recycle the sort of fractious debate around this and recycling the old ideas about what's driving MAID provision that we know to be untrue. I'm hoping that this will more inform a deeper discussion of what is actually driving requests for MAID, and a renewed effort to try to push research into these areas, to use this as a lever to improve provision of end-of-life care and palliative care for everybody, rather than just as acrimonious discussion around MAID question. And that's not to say that I reject all moral opposition to MAID. Quite the contrary. Many of my close friends are opponents of MAID, do not agree with it, think it is morally the wrong thing to do. And I respect them all the more for it. I have every ounce of respect for people who have strong moral objections. It's making sure that we act on those moral objections in constructive ways and not sort of obstructive ways. I think we owe it to ourselves, we owe it to our profession, we owe it to our patients to take that step. So just really changing the narrative. So that's all I'm going to say for today. And I want to thank you very much. And I'm very keen to hear a response and see if anybody has questions or thoughts about what I've said.
Well, thank you very much, James, for that presentation of a really important topic for our society, as you've laid out. We're going to take